Imagine this. You're totally in the zone, right? Deep into your favorite sport, or maybe just having a really active day. You pivot on the court, make a sharp cut on the field, land from a jump, and then pop.
Oof, yeah.
That sudden, unmistakable sound, an instant jolt of pain, and that really unnerving feeling that your knee just completely gave way.
It's a scenario that's unfortunately all too familiar for so many active people. Dreaded, really.
Exactly. And today, we're doing a deep dive into an injury that can sideline pretty much anyone, from a pro athlete to, a weekend warrior. We're talking about the anterior cruciate ligament, or ACL rupture. The decisions around treating it can feel incredibly overwhelming, and that's really what we want to unravel today.
And that's precisely our mission here. Our goal is to, well, really unpack the latest understanding of these ACL injuries and, crucially, explore the different treatment pathways that are available to you now. We'll be pulling insights from some pretty comprehensive sources, laying out the facts, trying to help you understand what's most important as you navigate what can be, a very complex topic.
Okay, so let's unpack this. What exactly is the ACL?
Right, the basics.
Yeah. If you picture your knee, think of the ACL like a really vital, strong sort of rope inside there.
A stabilizer.
It connects your thigh bone, that's the femur, to your shin bone, the tibia.
Yeah.
And this ligament is just absolutely crucial for stabilizing the knee joint, isn't it? It stops things moving too much.
Exactly. It prevents those joint surfaces from sliding, gliding, and rotating too much, keeping it all aligned.
And the name, cruciate.
That just means cross, because it literally crosses through the very center of your knee along with the PCL, the posterior cruciate ligament. They form a cross.
Got it. So how does this vital ligament actually get injured? What causes that rupture?
It's often those really explosive, rapid changes in direction that put the ACL at risk.
Like cutting movements.
Yeah, exactly. We're talking about pivoting, sidestepping, sudden stops, or even just jumping and landing awkwardly.
And sometimes direct impact, too.
Oh, definitely. Direct physical contact, like a tackle in football or rugby, can certainly cause an ACL injury as well.
And when you look at the high-risk sports, the list is, well, it's pretty long.
It really is.
Our sources mention things like skiing, soccer, basketball.
Yep, all the jumping and landing ones.
And various forms of rugby and football, AFL, rugby league, rugby union, even OzTag, which is non-contact.
Touch football, too, yeah. And netball, martial arts.
Mountain biking, motocross, gymnastics.
Yeah.
It really shows just how widespread this injury can be across a huge range of activities.
It does. And when we look at how common it is, the data is quite interesting.
Okay.
The annual rate of ACL rupture in the general population in Australia is actually pretty low, around 0.05% per person per year.
So not that common overall.
Overall, no. And this is the key thing for professional athletes in those high-impact sports. Basketball, soccer, the football codes, that annual incidence jumps significantly. We're talking 0.15% up to potentially 3.7%.
Wow, that's a massive difference.
It's huge. It really highlights the risk in those specific activities.
And here's something I found really eye-opening. The gender difference. Female athletes tear their ACL at a rate 2 to 8 times higher than males, depending on the sport.
That's right. It's a well-documented disparity. 2 to 8 times higher, yeah.
That is staggering. Why? What's behind that huge difference? Is it anatomy? Muscles?
It's likely a combination of factors. Research points to differences in lower body anatomy, like the angle between the thigh bone and the shin bone, the Q angle.
Okay.
There are also observed differences in muscle strength and, importantly, muscle activation patterns, particularly how the quadriceps and hamstrings work together to stabilize the knee.
And hormones.
Hormonal influences are certainly a factor that researchers are actively exploring as well. It's complex.
And it's not just about the first injury, is it? There's a big concern about re-injury.
A very significant concern, yes, especially for younger athletes. For those under 25 who return to high-risk sport after having reconstructive surgery, the incidence of tearing that ACL again, or the one in the other knee, is as high as 23%.
23%. That's nearly 1 in 4.
Exactly. It really makes you question what full recovery truly means in the long run, doesn't it?
Absolutely. So, okay, let's shift to someone listening who maybe just had a knee incident. How do you know if it might be an ACL rupture? What are the signs?
Right. The common symptoms, you might have felt that knee giving way, that sudden instability.
That buckling feeling.
Precisely.
Good.
Perhaps you actually heard an audible snap or pop sound at the moment of injury.
Yeah, that's the classic one people mention.
It is. Then there's usually instant, often intense pain, followed pretty quickly by rapid swelling around the knee joint.
Okay.
You might also have this ongoing feeling of instability, like the knee just isn't trustworthy. Pain when you try to put weight on it is common too.
And difficulty moving it.
Yes, pain and stiffness when you try to fully bend, which is flexion, or fully straighten the knee, which is extension.
But you might not have all of those symptoms.
That's a key point. You might not experience every single one. Some people have less pain initially, or maybe the pop wasn't obvious, but the instability is often a big clue.
So if you suspect it is an ACL injury, what are the immediate first steps? What should you do right away?
Okay, immediate actions are crucial. Our sources suggest initial first aid involves getting into a range of motion brace. Often they set it to allow movement between, say, 30 and 90 degrees.
To limit extreme movement.
Exactly, and you need to stay non-weight bearing, so crutches are essential. Don't try to walk on it.
Got it. Brace, crutches, what about scans?
Yes, you need to arrange for imaging pretty quickly. An emergency x-ray first, mainly to rule out any broken bones like a fracture.
Yeah.
And then, crucially, an MRI that's magnetic resonance imaging.
And is there anything specific about the MRI request?
Yes, the sources emphasize requesting a full sequence or a double oblique sequence with slices no thicker than 3 millimeter. This gives the clearest possible picture of the ligament and any other damage.
And timing matters for the MRI.
Ideally, yes. Getting the MRI done within the first few days after the injury is best. It helps determine the full extent of the damage before swelling, makes things harder to see clearly.
Okay, good to know. And for pain?
For pain management, standard paracetamol is generally recommended.
What about things like ibuprofen, Nurofen?
That's a definite avoid.
Hmm.
Anti-inflammatory drugs, the NSAIDs like ibuprofen, should generally be avoided in the initial phase.
Why is that?
Well, there's some evidence they might actually interfere with the body's natural early healing processes, so stick to paracetamol initially unless a doctor advises otherwise.
Right, so once that MRI confirms an ACL rupture, you're facing a pretty big decision.
You really are. It's a critical point.
Traditionally, it often seemed like surgery was the main, maybe only path forward. But things are changing, aren't they?
They really are. Recent developments have opened up new possibilities, new pathways.
But regardless of the path you choose, the goal is the same, right? Get the knee stable again.
Absolutely. The ultimate aim is always to restore functional stability to your knee, allow you to get back safely to the activities you enjoy, and of course, reduce the risk of injuring it again.
So what are these pathways?
What's really compelling now is how these different options compare and the evolving evidence behind each one. We're going to explore 3 distinct pathways today.
Okay.
First, the traditional one, ACL reconstruction surgery, or ACLR. Second, non-surgical rehabilitation, but importantly, with the option for delayed surgery if needed.
Okay, rehab first.
And third, a newer, quite specific non-surgical approach called the ACL Cross Bracing Protocol.
Cross Bracing Protocol. Okay, 3 distinct paths. Let's dive into the first one, ACL reconstruction surgery. What does that actually involve?
Okay, ACLR. It's performed under general anesthetic, so you're asleep. The surgeon makes small incisions, usually at the front of your knee. They use a small camera, an arthroscope, and various specialized surgical tools to work inside the joint.
Minimally invasive, sort of. Keyhole surgery.
Relatively, yes. Compared to older open techniques, they remove the torn remnants of your original ACL. Then they drill tunnels into your thigh bone, the femur, and your shin bone, the tibia, at very specific points.
Okay, tunnels. For what?
For the new graft. A graft is a piece of healthy tissue, usually taken from your own body. That's an autograft. Common sources are tendons from your hamstring or the patellar tendon below your kneecap.
So they take tissue from elsewhere in your leg.
Correct. That graft is then threaded through the tunnels and secured firmly in place, often with screws or other fixation devices, effectively replacing the torn ACL.
And you might need extra cuts for taking the graft.
Yes, depending on the graft choice, you'll likely have additional incisions where they harvest that tissue.
And recovery in hospital.
You'll typically spend at least 1 night in the hospital after the surgery, sometimes 2.
Right. And after you leave hospital, what's the immediate post-op recovery like? Pain, swelling.
Oh, yes. Post-operative recovery definitely involves managing pain and swelling. It's usually quite significant initially.
And crutches again?
Yep, you'll be back on crutches for about 2 weeks, maybe a bit longer, gradually increasing weight bearing as guided by your surgeon and physio. No
driving for quite a while, anywhere from 2 to maybe 6 weeks, depending on which leg and your recovery. Time off work varies hugely.
How so?
Well, if you have a desk job, you might be back in a couple of weeks, maybe working from home initially. But for manual labor, jobs involving lifting or lots of walking, it could easily be months off work.
Wow, okay. That's a significant impact. And then the rehab starts. You mentioned it starts immediately.
Absolutely. Rehabilitation after surgery starts pretty much straight away. It's vital.
What's the focus early on? Initially, it's all about managing that pain and swelling, gently getting the knee moving again, regaining range of motion, and starting to activate the muscles around the knee, particularly the quadriceps.
And then it progresses.
Yes. From there, a physiotherapist becomes your best friend. They guide you through increasingly challenging exercises, focusing on strength, balance, proprioception, that's your joint position sense, and eventually, sport-specific movements.
How long does this structured rehab typically last?
It's a long haul. You're typically looking at physiotherapy sessions 2 to 3 times a week for around 12 months, sometimes longer.
12 months. So return to sport is quite far off.
Generally, yes. Most recommendations suggest returning to pivoting or cutting sports somewhere between 12 and 18 months after surgery. But recovery timelines really do vary between individuals.
For someone active, that 12 to 18 months must feel like an absolute eternity.
It can be very challenging mentally as well as physically.
So given that long recovery, what are the big advantages of going down this surgical path? Why has it been the standard for so long?
Well, the primary advantage is its history. ACLR has been performed for over 40 years. There's a huge amount of data on it. This provides a measure of outcome certainty, perhaps. Surgeons are familiar with it, and patients often feel reassured by that long track record.
Predictability.
Somewhat, yes. Plus, a key benefit is that if you have other injuries in the knee at the same time, like a meniscal tear, which is quite common with ACL ruptures, they can often be addressed surgically during the same procedure.
Okay, so you can fix multiple things at once.
Potentially, yes.
But like any surgery, there's a flip side. What are the main disadvantages or downsides of ACL reconstruction?
There are definitely considerations. First, as we've said, it is an invasive surgical procedure carrying the inherent risks of any surgery, like infection or blood clots, though these are relatively low.
Okay, cost, waiting times.
Those are big factors. In the private health system, it can be quite expensive.
Mhm.
In the public system, like here in Australia or the UK's NHS, you might face a lengthy waiting list, potentially 12 months or even more just for the surgery.
A year waiting for surgery, then a year recovering from it.
Exactly. It can be a very long process.
Right.
And then there's the re-rupture rate we talked about.
That 15 to 30% figure.
Yes, depending on age and sport, it's not insignificant. The reconstructed ligament isn't immune to tearing again.
And finally, the rehab itself is a downside in a way.
The sheer length and commitment required for rehab is a major factor. A full year minimum of diligent work before getting back to high-level sport. It requires a lot of time, effort, and discipline.
Okay, so that's the surgical route. Now let's explore path number 2, non-surgical rehabilitation with that option for delayed surgery. How does that work?
Right, this approach takes a very different tack. The focus here is entirely on rehabilitation, specifically on strengthening all the muscles around the knee joint.
So using muscles to make up for the missing ligament.
In essence, yes. Think of it like this. Your ACL normally provides static stability. It's like that fixed rope, always there, preventing unwanted movement.
Right.
With this rehab approach, you're aiming to build dynamic stability. You train the surrounding muscles, the hamstrings, quadriceps, calf muscles, hip muscles, to work together incredibly efficiently to control the knee during movement.
So the muscles become the primary stabilizers.
They become much more effective dynamic stabilizers, compensating for the lack of the static ACL.
Is this common? It feels like surgery is usually pushed quite hard.
It depends where you are. This non-surgical approach is actually quite widely practiced, particularly in Northern Europe. Some public health authorities there often prefer it as the first line of management, based on their research.
Really?
Yes. And it's also become somewhat by default a common approach in the UK because of the long NHS waiting times for surgery. People start rehab while waiting, and many find they do well without the operation.
Okay, now this is where, for me, it gets really interesting.
Yeah.
The outcomes. How does this non-surgical approach actually stack up against surgery?
This is where the research has thrown up some fascinating, maybe even counterintuitive findings. A significant prospective cohort study back in 2014, and then a big meta-analysis in 2022, looked at this very question.
And what did they find?
Basically, they found very few, if any, significant differences in outcomes between groups treated with early surgery versus those treated with primary rehabilitation, with the option for later surgery if needed.
No differences. What kind of outcomes?
Across a range of measures.
Yeah.
Things like patient-reported knee function, muscle strength, time lost from work or sport, level of sports participation, and even the rate of re-injury or subsequent knee surgery, looking at follow-ups of 2 years and even longer.
Wait, so whether you have surgery early or try intensive rehab first, the result end up being pretty similar for many people.
That's what this growing body of evidence strongly suggests. It really challenges the traditional assumption that surgery is always necessary for a good outcome.
That is genuinely a game changer. If the outcomes are so similar, it makes you wonder why immediate surgery has been the default for so long, doesn't it?
It does. Part of it is likely tradition, surgeon training, maybe patient expectations too, the idea of fixing the broken part. But the evidence is prompting a major rethink.
And there was something else you mentioned earlier about the ACL potentially healing.
Yes, this is another really exciting area of recent research. It turns out that the ACL might have more natural healing potential than we previously thought.
Heal on its own, without surgery.
Under the right conditions, yes. Studies managing patients with rehabilitation only have shown that around 1/3 of ruptured ACLs actually display signs of healing on follow-up MRI scans.
A third.
Wow.
And does that healing matter? Does it lead to better results?
It seems to. That MRI evidence of healing is associated with favorable patient outcomes, better function, more stability.
And you said even more healed in the group that didn't end up needing surgery later.
Exactly. In that group, from the rehab first trials, the ones who started with rehab and were happy enough not to cross over to delayed surgery, about half of them, 53% specifically, showed MRI evidence of ACL healing at both 2-year and 5-year follow-ups.
So their own ligament effectively repaired itself in over half the cases who avoided surgery.
That's what the imaging suggests. It's quite remarkable.
Okay, so the advantages of this non-surgical rehab path seem pretty compelling then.
They are becoming clearer. First, it's non-invasive. No surgery, no surgical risks.
Right. Lower risk profile.
It has shown comparable efficacy to surgery in many studies for patient-reported outcomes. It's generally less expensive, too.
And the potential for natural healing.
That's a huge potential plus. And often, it allows for a quicker return to certain activities or even some levels of sport, maybe between 3 and 6 months, depending on the specifics and any other injuries. Much faster than the surgical timeline.
And critically, surgery isn't off the table entirely.
No, that's key. If you try the rehab route and your knee still feels unstable or you're not happy with the outcome, surgery remains a viable option down the line. You haven't burned any bridges.
Okay. What about the disadvantages then? Why wouldn't everyone just try this first?
Well, the main potential downside is that you might be left with what's termed an ACL deficient knee if the ligament doesn't heal functionally and the dynamic stability isn't sufficient for your needs.
So ongoing instability is a risk.
It's a possibility for some, yes. And there can also be a significant psychological factor.
How so?
Some patients feel a real concern, a worry about not doing everything possible to fix the injury. Even when presented with the evidence, the idea of not having the surgery can be unsettling for some.
Right, that peace of mind factor.
Exactly. Overcoming that mindset can be a hurdle.
Okay. So we've got surgery, ACLR, and we've got general strengthening rehab. But you mentioned a third pathway, something newer.
Yes, the third option builds on that idea of natural healing. It's a specific type of non-surgical rehabilitation called the ACL Cross Bracing Protocol, or CBP.
Cross Bracing Protocol. How is this different from the general rehab approach?
The key difference is the brace and the specific protocol around it. It's designed very intentionally to facilitate and enhance the natural healing potential of the torn ACL.
How does a brace help the ligament heal?
The protocol involves immobilizing the knee in a very specific position, usually 90 degrees of flexion, for the first 4 weeks. This position, combined with the brace, is thought to bring the torn ends of the ACL closer together.
Ah, okay. Creating a better environment for healing.
Precisely. It aims to maximize the potential for the ligament ends to bridge and heal naturally, while the brace protects the knee during this critical early phase. Then there's a gradual increase in movement allowed by the brace over subsequent weeks.
Interesting. Is this suitable for everyone with an ACL rupture?
No, and that's an important point. Based on current research and understanding, the cross-bracing protocol is likely only suitable for about half of all people who have an acute ACL injury.
Only half. Why is that? Depends on the tear type.
It often depends on the location and type of the tear and potentially other factors identified on the initial MRI. For the other half, surgery or the general rehabilitation approach might still be more appropriate considerations.
Got it. So what are the advantages seen with this CDP approach?
Well, the big theoretical advantage, or hope, is related to the quality of healing. It's hypothesized that an ACL that heals anatomically through this method could potentially be as strong and functional as the patient's original ACL tissue.
Wow, like getting your own ligament back, fully functional.
That's the potential goal,
Yeah.
yes. Like the general rehab path, it's non-invasive, it avoids surgery. Early results from clinical trials are showing promising efficacy. It's generally less expensive than surgery.
And surgery is still an option if it doesn't work out.
Yes. Just like with the other non-surgical path, if the outcome isn't satisfactory, ACL reconstruction surgery remains an option later on.
Okay, sounds promising. What's the catch? What are the downsides or challenges of the cross bracing protocol?
The primary challenge, honestly, is the brace itself and the commitment required.
How so?
You need to wear this specific, often quite bulky knee brace continuously 24 hours a day for 12 weeks.
12 weeks, 3 months in a brace.
Yes. For the first 4 weeks, locked at 90 degrees, then gradually increasing movement. It can be challenging, inconvenient, uncomfortable. Think about sleeping, showering, just daily life.
Yeah, that sounds tough. Like having your leg in a plaster cast for 3 months.
It's a very similar level of commitment and inconvenience. It requires real dedication and patience from the patient. That's probably the biggest barrier for many people.
And the rehab afterwards. Is it quicker?
No, that's another important point. Even if the bracing is successful, it still requires a long period of structured rehabilitation afterwards, very similar to post-surgical rehab. Return to high-risk sport is generally not recommended before 12 months.
So the bracing protocol doesn't necessarily mean a faster return to sport than surgery.
Not necessarily, no. The potential benefit lies more in the quality of the healed tissue, potentially restoring native anatomy rather than the speed of return.
Okay, that clarifies things. So we've laid out these 3 paths: surgery, general rehab first, and this cross bracing protocol. It's a lot to take in. What does this all mean for you, the listener, if you're facing this decision right now?
It means you have options, and the best option isn't necessarily the same for everyone. The landscape has really shifted.
And it seems like you don't always have to rush into surgery.
That's one of the most crucial takeaways from the recent research. Postponing the decision to have surgery, choosing to try rehabilitation first, does not seem to result in worse long-term outcomes compared to having surgery right away.
In fact, you said doing rehab before surgery might even be beneficial.
Yes, there's evidence suggesting that doing a period of prehabilitation rehab for maybe 1 to 6 months before having ACL surgery, if you do choose that route, can actually improve your knee strength and function after the operation. It sets you up for better success.
Yeah, makes sense. Getting the muscle strong and the knee moving well before the trauma of surgery.
Yeah.
And you mentioned those European trials where half the people who started rehab ended up not needing surgery.
That's right. 2 large clinical trials show that about 50% of people who were randomized to start with rehabilitation, with the option for delayed surgery, ultimately decided not to have ACL surgery within the first 2 to 5 years.
And they were happy with their knee.
They reported being satisfied with the outcome of rehabilitation alone. That's a huge number, avoiding a major operation and still achieving good results. It really underscores that non-operative management is a very viable path for many.
So what are the current recommendations then, based on all this evolving evidence?
The tide is definitely turning. Considering rehabilitation first, whether that's general strengthening or the cross bracing protocol if you're suitable, is now considered an appropriate approach for most people with an acute ACL rupture.
For most people.
Yes, that's supported by recent systematic reviews and expert consensus statements. Try rehab first seems to be the emerging recommendation.
But surgery still has its place.
Absolutely. Surgery may still be recommended or become the preferred option in certain situations.
Yeah.
For instance, if your knee remains functionally unstable despite a good course of rehabilitation, if you keep having episodes of giving way that limit your life,
Okay.
or potentially if there's very severe injury to other structures in the knee alongside the ACL, like complex meniscal tears or other ligament damage. Though it's worth noting the evidence strongly supporting immediate surgery even in those cases is still somewhat limited and debated.
Right. So rehab first is often a good starting point, but surgery is there if needed.
That sums it up well.
Okay. We have covered a tremendous amount of ground today on ACL ruptures. We've looked at what the ACL is, how it gets injured, the symptoms, the immediate steps, and then we really deep dived into those 3 distinct treatment pathways. The traditional ACL reconstruction surgery.
The non-surgical rehabilitation approach with the option for delayed surgery.
And that newer ACL cross bracing protocol aimed at natural healing.
exploring the pros, the cons, and some of those really quite surprising research findings that are changing how we think about ACLs.
It's clear the choice of treatment is a deeply personal one. There's no single right answer for everyone.
Absolutely. But hopefully, armed with this information, you could feel much more informed as you discuss the options with your doctor and physio. It's about understanding the evidence, your own goals, and the commitments involved in each path.
Ultimately, it's about restoring that stability, regaining strength, and getting you back to doing what you love, whatever that may be, safely and with confidence in your knee. So here's a final thought to leave you with. Given this growing evidence that a significant number of ACLs can potentially heal naturally with the right approach, and that delaying surgery doesn't seem to worsen long-term outcomes for many people, how might this evolving understanding shift our whole perspective? What does it truly mean to be fully recovered from an ACL injury? Is it defined by having a surgically reconstructed ligament, or is it more about having a knee that feels stable, functions well, and lets you live your life, regardless of how that stability was actually achieved? Something to think about.